Hello, everyone. My name is Raina Lari. It is such a pleasure to welcome you here today on behalf of the League of Women Voters Bay Area to our third session in our public health series. We have two amazing speakers here today we will introduce in just a moment. Today, we will discuss the role of racism and gender discrimination in explaining health disparities that, especially in the case of race, became apparent during the pandemic. Racial and gender inequality is a public health crisis. It has been said that being female is a health hazard in our culture. The same can be said about communities of color. Clinical studies and research are typically limited to white male patients, and women and people of color's medical issues are often minimized and dismissed by our medical system. We will also explore the long-term impact of discrimination and microaggressions on our bodies and talk about the strategies needed to improve health outcomes for women and for communities of color. Over to Marian Shovlin, our executive board member and co-moderator and co-organizer of the Public Health Series. Thank you.
Welcome, everyone. I want to add my welcome to Raina's. There are systemic gaps in healthcare and treatment based on race and gender. And this is one of a series of events that we're talking about, related events and items for that. In recent weeks, just last week, in fact, there was an article in a local newspaper about the potential kidney transplant patients who were not put on the transplant list due to an automated formula that indicated Black patients' kidney function was better than they actually were. And that was the result of calculations based on Black and non-Black patients being done differently. Between January 2023 and March, more than 14,000 Black kidney transplant candidates have had their wait times modified by an average of 2 years. Now, this is just one example of some of the disparities in our healthcare. Now, let's hear more from our expert speakers. And, Dr. Susan Rogers, the immediate past president of the Physicians National Program and assistant professor of medicine at Rush University. She is a longtime advocate for healthcare justice and racial equity and has testified before Congress and spoken to both medical and community audiences throughout the country. And Darcy Green, the executive director of Latinas Contra Cancer. And Raina will talk more about her when she speaks. But first, Dr. Rogers, who will talk about why we have inequities and how the medical system may be part of the problem. It's all yours, Dr. Rogers.
Okay, so let me share my screen. Oh, good, it worked. Okay. Well, thank you so much for inviting me to talk to you today. And I want to ask the question, is it racism or is it race? And I think that this country has asked itself and they have come up with the answer that it's race. And my answer is it's racism. And so I'd like to show some data here that I think will help you see what I am seeing. And it will explain why we have health inequities here. Now, I think one of the things we really need to acknowledge is that race is a historically derived social construct that has no place to be used as a biologic proxy. And that's what we have done. That's what the medical profession has done with race. It's used it the way it does with height or hair color, anything else that describes the person as if it's a biologic proxy. And that's really not it. And it is not, and I hope to show how it does affect our outcomes and the racial differences that come with that. So let's ask, what is systemic racism? And that's a term that you use a lot. And as a physician, a lot of the way we speak has to do with specific definitions for words and terms. And so what is systemic racism? We hear that term a lot, but it's really systems and institutions that produce racially disparate outcomes, regardless of the intentions of people who work with them. And that's why racism persists, even though people say, oh, I'm not racist, but they continue working within a system where they cannot make the changes that need to be changed because they're just part of the system. It's not dependent on their intentions, it's dependent on the system in which things work. So an estimated 80% of health outcomes really come from social, economic, environmental, behavioral factors. We know these mostly by the terms social determinants of health, housing, food security, personal safety, all of that. And reform efforts should include training more Black healthcare physicians and professionals. But we know now with the destruction of affirmative action, that is going to be more and more difficult. But inequities did decrease when we had Medicare and Medicaid that allowed more people of color to receive health care. And I will get some more about that in a few minutes. So as I said, we need to be clear about the definitions when we use terms. So what are health disparities? Well, health disparities just refer to differences in health outcomes, differences in anything, and they're just a difference. They don't infer any reason, any cause, whether it's fair or not. And so, oops, I didn't mean to do that. But it's just a difference. So disparities can be across many dimensions, including health. It can be, race, socioeconomic class, gender, disability status. Those create differences in outcomes. But when we talk about inequities, what does that mean? Well, the term inequity itself has a moral and ethical dimension. It infers an unfairness. It infers that something is unnecessary, that it shouldn't be there, that it can be avoided, and it is unjust and unfair. Now, the World Health Organization uses the term inequities. The United States continues to use the term disparities. So I would suggest when you can think about it, that you use the term inequities when you discuss the system that occurs here, because it doesn't need to be here. It's created to be here. So we have to ask ourselves, are the biological differences among races what is causing inequities? And I have here a list of some things that have been adopted as fact, but they are really just myths, and they have persisted through years. And one of them is the craniotomy sizes, and this was determined back in slavery, and what they found was that the brains of slaves were smaller than those of whites, and so they inferred from this that was why they were less, their cognitive function was less, they weren't as smart or whatever. However, that has been proven false. However, that myth continues to persist. And one of the things that it did do, I don't know if you've heard of the term race norming in the NFL, and this was what was done when it was found out that many football players had what they call traumatic encephalopathy from repeated head injuries playing football. And so what happened and this was discovered by an African physician in Africa, I forget the country that he was from, but he was the one that found that it was this repeated trauma. And so this was, it started affecting, was being looked for, and people saw it more often. But when they decided how to compensate these football players, what they did this thing they called race norming. And with the assumption based on craniotomy sizes studies that were found in slavery days, they felt that, well, Black players started at a lower cognitive level. And so wherever they were now, they had lost as much as a white player who started at a much higher level because he was white. And so he lost much more function. And that term was called race norming in the NFL. It accepted as fact that Black players were not as smart to begin with, so whatever they lost was not as much. And they clearly lost tremendous amounts of money. Because remember, these men were young. These weren't 80-year-old people with, you know, Alzheimer's. These were young men who lost the ability to function, so their needs were much greater. And so this race norming in the NFL was finally called out. And I don't know if players have gotten a fair compensation from this everywhere, because of course this was going to be denied. But this is these extensions of myths that were founded in slavery days are still used by physicians today. Why is someone, if I was teaching you medicine and I told you, well, we need to treat this disease this way, and I show you an article from 1950, you'd say, what's wrong with Dr. Rogers? Why is she doing that? And yet we have esteemed physicians who are doing the exact same thing. And they're not looking at data, they're looking at myths. And we can go through this whole list. I don't want to take all the time, but even vital capacity, which was determined back in slavery with the lungs in terms of how much work someone did, and they said that the lungs were weaker in slaves, and so they had to work harder so they could build up their lungs. That's been shown not true. Eugenics, that some people's bloodlines are less good, that allows people to feel okay with eliminating races. And this is still being talked about today. It's being repeated what the Nazis said about poisoning the line of our country, and that's being repeated today. Clinical trials, they're not, you know, there's not many people in Blacks who want to engage in clinical trials because of the history of this country. There's a term, excited delirium, that the police have come up with, and they have got doctors to help support this. And this is how Black men, when they get stopped or arrested, they get excited, they may get more aggressive, but they have made this a disease. And they felt that this disease needed to be treated by a drug that often killed these men. And there are doctors who support this, even though there is no data to support this. So what has happened is that these biological differences that people have said are due to facts, we have proven this, really are not true. And it continues the ability to use myths to decide what is right and what is wrong. And I'm going to talk a little bit more later about algorithms that use race as a fact in deciding how things should be done or not done, when it really is based on myths. So it's these algorithms, which really are just sort of tools that we use in healthcare, and it's called evidence-based medicine. And that is when we go through algorithms, we go down steps, and this is how we decide what to do, how to diagnose, how to treat. And they're algorithms, and we put certain data in there. And what has been done is race has been embedded into the data and into the decisions of healthcare. And this is really just propagating web-based, race-based medicine, because it's not based on fact, and I'll get into that in a few minutes, but these differences are not rooted in real data. And so what has happened is that the whole concept of race really came up in this country when we look back at the history. Why do we come up with race anyway? Because when Europeans came to this country, they came as Spanish, they came as Italian, they came as French. They came from their origin, their country of origin, and that's how they define themselves. But what had happened is, as Blacks became more populous here, they had to define who could be a slave and who could not be a slave. And that's where race came in. And race was used to define that. It defined the role a person would have in this country. So it had to be the white people who could not be a slave, and they could own slaves. Black people would be a slave, and that defined their role here in this country. It had nothing to do with science. It had to do with culture. It had to do with who could do what and who could not do what. And so the whole concept was, it was a social construct. It wasn't based on science. Now, we did come up with the Genome Project, the Human Genome Project, that started in 1990 and it was completed in 2003. And that finally should have answered this question, that we are all the same. All humans, regardless of whether they were born in Africa, Europe, Australia, Antarctica, the genome was 99.99% the same. So there wasn't a genetic difference in how people determined race or what determined race. We were all the same. However, we've embedded race into the basic data and decisions. And these, like I said before, these algorithms propagate race-based medicine because we refuse, the healthcare system refused to acknowledge this. So let's look back a little bit to, we all have heard of W.B. Du Bois, and he wrote a book back in 1899 called The Philadelphia Negro. And what this was is he studied why are Black people living in Philadelphia dying more and more of tuberculosis. And what he found was it was really the social determinants of health that did this. It was the fact that they lived in high poverty, they had poor food resources, there was crowded housing, there was poor sanitation, and that's why they died more of tuberculosis, not because of their race, not because Black people were more likely to die because they were inferior. It was because of the social determinants of health. He found this out in 1899. And a lot of what he did, this public health service still uses some of his techniques, and he founded the way we do this. And so he provided evidence that clearly showed the importance of living conditions and the role of socioeconomic status as factors that contributed to higher morbidity or mortality. It was not race. It was these social effects that came from the way where people were forced to live and how they were forced to live. And shoot, I didn't change some of these. I'm going to skip ahead and I'll come back to that. And so what has happened when we look at how people live, where they are allowed to live, this is a picture of in Illinois and in Chicago, actually. And what this black line is going up the middle, it shows one of the public transportation rail lines. And if you start at the bottom, that is in a large minority, poor minority community that is mostly Black. And that was because with redlining during FDR's New Deal, this was where Black people were forced to live. And it's a poor community. And if you ride that train all the way to the north, which is mostly white and much more economically successful, the life expectancy falls 30 years. 30 years. So living in a Black community, a zip code in the Black community is a higher risk factor for early death and more morbidity than it is living in, than what you do. You have poor access to things, and I'll show you that. But this is what happens in communities and where Black people are forced to live. And even if you look at the air quality in some of these neighborhoods, and the green is good air. And if you look at where the bad air is, that was where redlining communities were. And so this is why Black people are more likely to get lung disease. Children are more likely to have asthma. It's not because Black children's lungs are worse, it's because they play outside in communities with bad air. And also in poor housing, you have more issues with mold, you have more issues with water sources that are clean. So a lot of this is just related to where people are forced to live because of racism. It has nothing to do with their genetic makeup or what predisposes them to more likely. It's the genetic, it's the physical area where they are forced to live that causes poor people, especially Black people, because there are more poor people who are Black and live together. who are forced to succumb to be affected by poor water, air, and other resources. And this just shows is a slide that talks about the location of pharmacies in poor communities. And what it shows is that if you look at the bottom two lines, that areas that are all segregated, either white or Black, that those have fewer pharmacies, so that people who live in these communities who need medicine often don't have access to a pharmacy, which is a big problem now because we have networks where you have to go to a certain pharmacy to get your medicine. Let's say the closest pharmacy is a mile away. If you have heart failure, you can't walk a mile up and then a mile back before you can get your medicine. So you don't have access to the things that make you healthy. This has nothing to do with race. It has to do with where you are forced to live. And this is just where the ICU beds, if you look at lower income communities, they often have 0 ICU beds. And here you can see that a community where the mean income is less than $35,000, less than half of these communities have beds. So when people get COVID, poor people who live in poor communities with crowded housing, with poor air, who get COVID, this is what happens. They often die because they cannot get health care. There are no ICU beds for them to seek care. So this whole idea that there's something with Black people that makes them more susceptible to COVID was not true. It was the physical circumstances where they were living, the environment that they were living. It was not because of their genetic code. It was because of their zip code. And one of the things that the AMA said early on in the COVID pandemic, the president of the AMA was asked, why are Black people so affected adversely from COVID? And her response was, well, we'll need to do studies for that. As if this should have been a knee-jerk answer, but we don't want to admit this in this country, that we have done things that make life worse for others. And by blaming race, it allows us to not acknowledge that racist behavior, such as creating communities without the assets that people need to live, and we just hide the effect of racism and the environment and how people are not able to live as well. If we look at heart failure admissions, and this was done in this is a group of Black physicians who in Boston Mass General Hospital, a highly esteemed hospital in Boston. And what they found was that patients who were admitted with heart failure really didn't get access to the specialized care. And that was because of algorithms that said if they were Black and they didn't spend as much money on healthcare, they weren't as sick. And so this is how the algorithm works. So it made Black people's outcomes worse, because if they hadn't spent as much money, they didn't get to go to that floor. And when you think about it, if you don't have any money to spend, no matter how sick you are, you will never spend a lot of money on healthcare because of the way it is. So we have these, and this is at a highly esteemed hospital. And they too believe the myth of race, that it makes you more likely to be affected by certain diseases rather than by the environment and what you're succumb to. Now, I read this article. This story actually kind of shocked me. It's about biases and autopsies, and I never really thought about this much. But this was an article in the New York Times that told the story about a woman whose child, she'd come home from work, he was a little sick, he had had a cold, and he just got worse and worse over the evening. And then she finally took him to the emergency room because he was not getting better and he was actually getting much worse. And so while he was in the emergency, he had a cardiac arrest, and they took him in. They worked on him, you know, for over half an hour. They worked on this young child, and I think he was less than a year. So this was a young infant. They worked on him for a long time, and they could not revive him. And so by law, if you die in the emergency room, unless you are known to have certain diseases, you get an autopsy. And so the pathologist diagnosed his death as child abuse. And the reason he justified this diagnosis was because this child had undergone cardiac resuscitation, so there were bruises on his chest. He had multiple stick marks from where they tried to put IVs in, and all of this stuff. The doctor never looked at the chart to see what had gone. And this poor woman ended up spending a year in jail. She not only lost her son, her baby, she spent a year in jail until she was acquitted of murder, of child abuse and killing her daughter. So this was just a bias, that this is what poor Black women do. They abuse their babies. And so, and it's just a prejudgment. And this is what happens even in medicine, that physicians are not immune to bias. And in fact, they are a big part of the problem, because it would not persist if they did not use bias, but they looked at data the way they're supposed to. Skin color and dermatology. This is one of the drawbacks, in that rashes look different on dark skin. And if all the pictures in the book are on white skin, it's sometimes difficult to diagnose things. And there's many skin conditions that make people very sick and can cause death. It's not like you just don't like the rash or that it itches. So this is a big problem. It's become a lot better, I will say. One of the things too, and how we fund care. If we look at sickle cell disease and cystic fibrosis, sickle cell disease affects about 1 in 295 children, whereas cystic fibrosis affects 1 in about 2,000 children. So sickle cell disease is a much more common disease. And it's a chronic disease. The children don't grow normally. They miss school because they're sick. There's a lot besides just the effects of the sickle cell disease. So why is it that they don't get funded? If you look at the number of patients, the bar graph on the left, and then if you look at how much the NIH funds, they still don't fund, decide on their need to fund based on need. And then even in foundation funding isn't decided on who is in most need, who has the most children affected by this. So this is a racist way to fund healthcare. If you let people decide, and even the NIH does not decide always on basis of need. There is bias within the NIH. If you look at healthcare by minorities, and this is a phenomenal book. I don't know if you've had a chance to read it. It's a very difficult book I think to read, because some of the stories that she described are so horrendous. But it just talks about how, and I know that we're all aware that slaves were grossly mistreated, but it didn't end with slavery. It didn't end with the Tuskegee Institute with syphilis in the 40s. So that these things persist. They even persist in today's world. There are migrant women who get hysterectomies done for no reason other than to stop the bloodline from that group of immigrants. So that this still persists. And one of the things that this does is it allows this to be hidden, and that we don't look at this as an active problem. It's presented as if it's all over. And it's almost as if you would say to a woman who was abused that, well, if you were just nicer to your husband, he wouldn't hit you. And that's the argument that people give about medical apartheid, and that Blacks should be nicer and we should be more welcoming to the healthcare that's provided, and then you wouldn't be the subject of these absurd trials, when it's not the fault. And here they are still blaming the victim. And this is why the abuse goes on. I'm going to skip this. But you know what I realized is that I put on the wrong set of slides here, because there was one slide that I wanted to show you that it was a picture that I took. I was in Africa maybe about 8-9 years ago. and we were in Cape Town, and we went up to Johannesburg, but we walked by this courthouse, and in front of the courthouse was a big plaque, and it talked about how they affected, how they decided, how they assigned race to people. Because it wasn't just dependent on one drop of blood, but there were 8 races that you could be in South Africa. And so it all depended upon how dark or light your skin was, how curly your hair was, what your facial features were. And so what happened, people were assigned races. It didn't necessarily matter what your bloodline was. You were assigned a race. And so families were separated because one child may have been too dark or another child may have been too light, and they were separated. So this whole thing about race is arbitrary. It is not based on science. And here in this country, we continue to use algorithms that use race as a science. And I think as physicians, this makes us the big part of the problem. And why do we have algorithms that show that if you are Black, you are more susceptible to this disease, even though there is no data that supports that at all? You are not more susceptible to something because we all have the same genome. We all have the genome that the human race is one genome. Now, there are ethnic differences. There are a few differences, things like sickle cell, if people have lived in an area where the progression of that disease that was caused by an infection, it'll become more greater in that community, but that doesn't make the body so genetically different. It's just that one specific disease that it helps. So we've taken, healthcare is the same thing, has done the same thing as housing. It's done the same thing as education. It's decided who can get what care and where. Even though with this healthcare is supposed to be evidence-based, we are not doing that. And I think that it's our responsibility, not just as physicians, but all of us that are involved in healthcare to fight against this, because it's not going to go away by its own. And even now, it's still being used. And it's not, the Genome Project is actually being ignored. And even those algorithms that the Genome Project said, this is not based in fact, doctors are still doing that. So why is it that we just ignore facts and we follow the myths? And that is why we have these inequities. It is not because of race. It is not because of differences in the makeup of people. It is because our healthcare system is just another part of the racism that belies even in the whole world. It's not just in the United States, but it affects housing, education, and healthcare, all of these things. So I hope I didn't take too much time, but thank you for listening.
Thank you, Dr. Rogers, for your excellent, very illuminating presentation. I'm delighted to introduce Darcy Green, our second speaker. She's Executive Director of Latinas Contra Cancer and brings with her 20 years of community activism and public policy experience. Darcy served as chair of the Santa Clara County Race and Health Disparities Community Board. She will talk about her work organizing Latina patients to make demands of our healthcare system for better outcomes for them. Thank you so much.
Thank you so much. It's an honor to be here. Thank you for the invitation. I almost for a moment forgot I was a speaker because I was such a participant in that last presentation. Dr. Rogers, thank you for all that you shared. And you're going to hear some redundancy in the work that we're doing at LCC and how we, and some affirmation, right, from what we are also seeing on the ground level with patients as we are doing the work of navigating and supporting patients who are trying to access care. If you would let me know what time should I stop speaking, that way I can make sure to get you all out of here on time.
20 minutes would be great, actually.
Perfect.
Thank you.
I will stick to that. And I want to just make one note. I see my mother on the call, so I just want to acknowledge her. Her name is Danette Green. I think she's a member in the San Jose chapter. So thanks, Mom, for being here. Let me go ahead and get started. I'm going to share my screen with the presentation that I put together here. There we go. And if I can now just figure out how to present it. There we go. Okay, are you all seeing my presentation? Fantastic. Okay, so my name is Darcy Green, Executive Director at Latinas Contra Cancer. Here is a picture of most of our team. We are health educators, patient navigators, patient advocates. We do survivorship support, and we are also community organizers. And I'm going to talk a little bit today about also the issue of race and gender, but primarily race and healthcare, and some of the things that we are doing to not just overcome health inequity at an individual level, not just overcome health disparity, but our work in systems to try to create a different way for people to access healthcare under the umbrella of such an inequitable and unjust system. Okay, so who am I? Very quickly, I am a Latina, I am a mom, I am a sister, I am a friend, I am an organizer, I am an advocate, I am a former elected official, I am a county commissioner, and I'm a patient advocate. I'm also an East Sider. I always start with these identities, and I encourage us all to think about the identities we carry with us every day, because these identities often will shape the way we interact with systems, the way we view systems, and they certainly shape the way we show up in conversation. So all of these different identities that I'm bringing to this presentation today come from the lived experiences I have, right? These in each of these words holds a point of view, holds a lived experience, holds the experiences that I've had living here as a third generation resident of the city of San Jose, county of Santa Clara. And in all of these are wrapped up the ways that I view the world. And just to point out something about that last slide, when we think about bias, right, and we all have aspects of bias, oftentimes the way that we have shown up in the world, the different identities we hold, and the different lived experiences we have can also impact the bias we may have toward other communities. I want to start off by just saying, before we get into this slide here, racism and patriarchy in our healthcare system actually costs human life, right? And I think that was very apparent from the presentation we just heard from Dr. Rogers, right? These are not just theoretical buzzwords that we often hear, particularly in political climates, especially during election time. We hear a lot of conversation around racism. In the context of health, it's so important to understand that in addition to being an academic term, in addition to being a theoretical term, in addition to being the systems term that we heard, there is an actual human life cost, right, to the persistence and the baked in racism that exists in our healthcare system. And when you add on top of it this foundational aspect, right, of racism that has always been present in our healthcare system, it was part of the founding of how we understand healthcare here in the US now. Racism was always present. When you add on top of that patriarchy that exists, and then you add on top of that the healthcare economy that we exist in, this kind of capitalist way of providing healthcare, not as a social service, but more as a commodity, those three things combined are this recipe for unnecessary cost of human life and unnecessary human suffering. So if you can bring yourself to accept that, right, to accept that racism is ever present in healthcare, it's actually baked into it as from its foundation, that patriarchy persists in healthcare and it shows up in the bias, not only in many of the aspects of healthcare being male dominated, but also the beliefs we have about women in healthcare. And adding on to that, this persistent tie to productivity as a way of earning health, right away, as a way of earning healthcare. And when you aren't productive, the way that your access to health changes, all of that contributes to health disparity, health inequity is behind it, right? So it's important for us to acknowledge and accept that about the healthcare system. So health is political, right? Health is political. It's political because, like any other resource in the community, your access to health, right? So whether that's healthcare, whether it's a neighborhood park, whether it's a safe street that you can bike on with your children or your family, whether it's air, whether it's how close or how far you live from a freeway system and freight, all of these things, right? Your access to health, your ability to have good health, your whether your health is, you have poor health, all of these things are political because your access to it greatly depends on who holds power and how they choose to distribute public resource, right? So like any other part of our society, health is also political. And health inequity, just like social inequity, is not a natural occurrence. And because these are we speak about health disparity in these kind of polite ways, it's easy for us to believe that health disparities are just foregone conclusions, right? That some people will just disproportionately experience the impact of certain health conditions, certain social determinants of health by a way of just natural occurrence, right? The way
just about all these sort of
right. The way that trees grow, the way that birds
healthcare
fly,
for blacks
it's
and
just
browns differs
a
from
natural
healthcare
occurrence.
for whites, which you probably saw.
That sounded like a really good discussion. We could get into it later. I want in on that conversation. These are not natural occurrences. Health inequity persists and it grows because of policies and laws that bake inequity into our systems, right? So it doesn't just happen. It doesn't just grow that way organically. This is an intentional thing, right? Health inequity is a choice that we make. The fact that some people have disproportionately worse health outcomes, and that usually tends to be by race, by income, by geography, those are not natural occurrences. Those are choices that we're making either through policies that are baking that in or through an absence of public policies protecting those communities that are more likely to be impacted by it. Now, you may think about this slide and say, like, this sounds frustrating, overwhelming, but when I put my community organizer hat on, when I put my advocate hat on, when I put my, defender of all things justice hat on, this is actually a very hopeful thing to think about, right? Because we created these systems this way, we can create new systems, right, too. And part of that comes from the acknowledgement that these are choices, right? We are choosing for some people to experience adverse health outcomes unnecessarily. Health inequity is largely predictable and therefore largely preventable. When we think about the pandemic, right, and COVID-19, particularly here in Santa Clara County, we know that there were some communities, Latino community, low-income communities, undocumented communities that were largely disproportionately impacted by the pandemic. These are communities that had less access to sick leave, right, and ability to work from home. Communities that had less abilities to isolate because of overcrowding in housing or the need to live multiple families to a home because of the cost of housing. Pre-existing conditions that are also systemically enforced onto them. It was not a surprise to know or to see the communities that were disproportionately impacted by the pandemic, because these are the same communities that are always disproportionately impacted by public health crisis, chronic condition, chronic disease, environmental crisis. These are predictable, right? Because we have data, right? And we have the research to show that, and preventable, but not prevented because of many times lack of political will, lack of allocation of resource, and sometimes because of racism and patriarchy and classism. So race, and I'm speaking to the issue of cancer here because that's the issue we work in, and this is what we see every day. Race should not be a factor in your health, right? Race should not be, and as we heard from Dr. Rogers, race itself is not the factor mostly in your health outcomes, right? It shouldn't be that your race specifically is the factor, and yet we hear oftentimes the word race used in health, and really what we mean is racism, right? So race is only a factor in your health outcomes because racism continues to be a factor in our healthcare system, right? It really is as clear as that. And not only is it a factor in our healthcare system, racism as a system, right? A system that is conspiring based on all the different intersections of our identities is a factor in healthcare, and also a factor in many other systems that govern the way that we live or that impact our social determinants to our health. Something we think about a lot at Latinos Contra Cancer, right? Because we are an organization that helps people on an individual level, right? We provide services to individual patients, our clients, who are accessing preventative screenings, who are accessing cancer treatment, who are accessing support groups, trying to access health insurance, all of the ways that we access the healthcare system. We help them at an individual level to overcome the barriers and the obstacles that they face in trying to access care. We do this, though, knowing that you cannot individual behavior your way out of systemic health inequity and systemic health injustice, right? And so think about it this way. My grandmother, right? My grandmother who passed away of breast cancer, did all of the quote unquote right things regarding lifestyle, right? All of the things we hear, right? Maintaining a healthy weight, don't drink too much, don't smoke, make sure you're exercising, make sure you're managing all of your stress, make sure you're doing all of the things that will help to lower your risk for cancer. And then you find that someone who has done all of those things, right, the healthiest person, quote unquote, based on standards at that time, then gets diagnosed with cancer, right? And you wonder, okay, how is it that some people are doing all of these quote unquote right things at an individual level and yet are diagnosed with a chronic condition that ultimately, or chronic disease that then ultimately takes their life? And then you dig a little bit deeper and you realize my grandmother, right, was a worker in some agricultural setting and may have been sprayed with pesticides. My grandmother, as a Spanish-speaking woman in Eastside San Jose, may have been exposed to lots of microaggression and racism and bias across her time. My grandmother, who lived in an area that became increasingly less affordable, may have struggled with the stress of finances. There's all of the other systemic things that were really out of her control that contributed to raising her risk for cancer. So when we think about like, who is it serving to put so much emphasis on individual behavior, right? So much shame and guilt on people on whether or not they are the sole contributor to their chronic condition, when in fact they live within systems, right? And within institutions that have racism, patriarchy, classism embedded into them. And really there was no individual behavior that would have been stronger than the existence of those isms and systemic issues that they are living within. So these are the things that we have to come to accept about the healthcare system if we are going to make an impact in not just helping people navigate health disparity, not just helping people navigate obstacles to care, but eliminating those disparities and obstacles from existing in the first place, because their very existence is in fact an injustice, right? And helping them to overcome them is not the justice part, right? Eliminating it and making sure they don't experience it again, that's the justice part. I want to quickly just talk about the Santa Clara County Race and Health Disparities Board. I had the honor of chairing this board for 2 years. It was a board that was created out of the pandemic because there was such an apparent race-based disparity in the healthcare system that became much more apparent because of COVID-19 and the pandemic and all of the things that went along with that. For 2 years, we met and we explored with intention, not social determinants. We explored with intention racism in the healthcare system itself. Because while social determinants are big factors, obviously, in the way that we are able to experience health, right? Where we live, our access to education, civic participation, employment, incarceration, all of those things are big drivers of health. Sometimes our over-reliance on looking only at external social determinants of the healthcare system, then doesn't create the space for us to be curious and examine inward about the racism that exists very clearly in the delivery system, even here in Santa Clara County. And so we published a report that came out the end of last year that gave, and I'd be happy to send this out, and I hope you were able to take a look at it. It's a beautifully drawn up report too, with a lot of beautiful imagery and firsthand accounts of blatant racism in the Santa Clara County healthcare delivery system. And it really does no good to think about whether good people or bad people are doing it, right? One of my favorite quotes in the abolition space that I do organizing in is like, it really is not very consequential when you hold power, whether you are a good person or a bad person, whether you're doing good or doing bad with the power that you're holding. And so, really good people can, do racism, right? Really good people can have bias. And when they are in positions of power over someone else, that bias can then turn into harm, right? Material harm. And that's what we find in healthcare systems, where bias and bias among individuals and racism among systems continues to persist. And we found it here in Santa Clara County as well. So I do urge you to take a look at this report. I want to talk a little bit about, in light of all of this, right, in light of recognizing that racism as a system exists in the institution of our healthcare delivery system, that patriarchy absolutely also exists within our healthcare delivery system, and that we can't individual behavior our way out of it, I want to talk a little bit about what LCC has, Latinos Contra Cancer, has decided to do as our ethical response, really, to all that we experienced and witnessed during the pandemic, when so many of our clients, Latino, low income, many undocumented, many already just struggling to stay afloat prior to a cancer diagnosis. And then you see this, on top of that, the impacts, economic and health impacts of the pandemic. Our ethical response to that was, it was no longer good enough for us just to help people overcome at an individual level race-based health inequity, right? That we had to do something to evolve from a direct service provider to an organization that built the power of patients to make demands of healthcare systems and to change or create alternative ways of accessing care for themselves. So when we think about advocacy at Latinos Contra Cancer, we think about a process of engagement that creates the space for us to be an active participant in the systems that govern and impact our lives. Just to be very clear here, our theory of change, what we believe is going to make the difference, is a powerful patient population. There has to be something that creates balance or helps to get near balance around the power dynamic that patients experience when they are in their healthcare setting. When you're a patient going into a healthcare setting and you are experiencing racism or bias, it can be very difficult to advocate for yourself, particularly when Black and brown women, their advocacy is often experienced and interpreted differently than white patients are. We often will hear of our clients advocating for themselves and then being labeled problem patients, right? Or advocating for themselves and being labeled difficult, or advocating for themselves and being labeled unruly. And so even what showing up for yourself as a patient in a system that has built into it racism, and with people who can't help but have some bias toward you based on your race or your gender or your country of origin or your documentation status, how do you effectively advocate? And our belief is that the only thing that is going to create the leverage for systems change is collective power of patient, is building the collective power of patients to do this type of advocacy that isn't just advocacy around a condition or advocacy around health education, but is really advocacy that allows you to be an active participant in those systems that govern your lives, and which way we think about turning healthcare systems and our relationship to them into something that's similar to the way that we have relationships to parks and libraries, right? Where these are community assets that belong to the community, and those barriers to entry should be like those of libraries and parks, right? Not as difficult to access. before I go into just the two programs that we have, I just want to throw this out there. We think about this again a lot at LCC. We made this world, we can make a new one, right? Again, the hopefulness that we have to have, and hope is a discipline also being one of my favorite quotes. We have to believe that we can eradicate racism, or we can move toward eliminating the impacts of racism in healthcare. And that does come from first accepting that it exists and always has, but also a willingness to imagine a healthcare system that doesn't exist now. And what would it take in order to get there? And we believe it is the most impacted patients who should be at the forefront of that imagination. So one program of the two I'm going to speak on is Defensoras, our healthcare advocate training. We started this training 2 years ago. We've now had 8 cohorts, 95 graduates. These are Latina patients. The only qualification to get into this cohort is you've somehow at one point in your life identified as a patient or a user of the healthcare system, and you identify as Latina, whatever that means to you. We purposely try not to recruit healthcare workers or folks who have experience in healthcare or existing leaders. The idea behind this is that we as a community actually are very good at advocating for ourselves. We have folks who come from different countries, who have navigated themselves to this country, who have navigated social services. We are good at standing up for ourselves. It's that healthcare is unnecessarily complicated and extremely complicated in its own language. So we have this training that isn't health education and isn't a service we're providing. This is a political education. And we take people through the history of healthcare as the first module, and we start with slavery. We start with the foundation of our country, and we help people to understand why racism exists today and how it was always there, and how it's been baked into it, so that we can fully understand the ways that we need to dismantle those pieces that are harmful. And then we go into some of the more traditional healthcare related topics, right? Insurance and patient rights and effective advocacy, social determinants. We also go into like, what's an HMO, what's a PPO, like all of the technical things. And then we move people into the data, like the race-based data around health equity in the Latino community, to just get a big understanding that the individual injustice that you're experiencing, one, is not your fault, and two, you're actually one of many people experiencing it because it's actually a systemic issue. And then we transition the course into, so what do we do about it? And we talk about other movements around healthcare justice, Young Lords, Black Panthers, different movements that have come from our own country that have moved us toward thinking about healthcare as a whole package around social determinants, and allow us to fully examine race and racism in healthcare. And then we talk about community organizing, and we move people to that. So this is a 10-week course. It's 2.5 hours each week. It's very rigorous. There's a lot of homework and group education. And what happens by the end of it, once we've taken somebody through the history of healthcare, how it was founded, the medical association, like all of the things, all the way to the end around taking care of yourself and your community and the role organizing can play if we are to organize patients the same way we organize students out of schools or workers out of unions. If we're able to organize patients out of healthcare systems, what might become possible? What we find is not only are our participants by the end of this cohort super fired up and angry about the health injustice that they've learned about how preventable and how much of a policy choice their suffering is, they become then ready to join an organizing movement to do something about it. Just some of the numbers on who we've trained and how many folks. And so after doing 2 years of this Defensoras work and thinking about, okay, what's this next step? Well, obviously the next step was organizing, right? So we hired organizers. We have an organizing committee, and we've just launched our first campaign. All of this being deeply embedded in the work of racial health equity and overall justice in healthcare, and continuing to hold up and acknowledge that individual behavior and individual service is not going to be enough to achieve health justice for all patients in our county, particularly when you also can accept and acknowledge that when someone has a language barrier, when someone has a transportation barrier, when someone has an economic barrier, it actually isn't the barrier of the patient, right? It is the inadequacy of the healthcare system to meet the needs of all of their patients, right? So we started organizing, we've done a listening campaign. We've talked to a lot of patients in Santa Clara County, particularly patients of color, particularly Latino patients, and we've learned a lot of things, right? And we started with the current Patient Bill of Rights written by the American Hospital Association, and we've examined, right, and been really curious and done a deep dive around the current Patient Bill of Rights, because our current campaign is drafting a regional alternative Patient Bill of Rights that is written by patients who have experienced race-based and gender-based health injustice. So these are some of the things that we've learned, some more of the things that we've learned. And obviously they're what you would expect, right? Not listen to so many people we talked to who were certain that they had a symptom of cancer, went and because of bias were told, no, you're just overweight. No, it's because of the laborious job you have. That's probably just an ache in your back. And 6 months later find that it was cancer the whole time, right? So there is bias that exists across the cancer continuum as well, that causes this unnecessary shame, guilt, human suffering that we're looking to alleviate. This is the timeline for our campaign. So we're right now in an up and running campaign to draft an alternative Patient Bill of Rights. And I'll show you a little bit about what was on this. And again, this being what our response is to racism in healthcare. And what is our part, right? What can we do as patients to help not just have a voice at the table, right? There are plenty of ways that patients can fill out surveys or be part of councils, but to actually have power, right? For patients to actually have power to change something within their healthcare system. And to us, this is a radical notion because of lots of ways that the system reinforces that you shouldn't talk about your personal healthcare, right? That you shouldn't talk about your personal story, that you should be so grateful for the care that you get, and in many ways, maybe. But receiving quality care isn't an act of charity, right? That is your human right. Your basic human right is to healthcare. When you don't receive it because of racism or patriarchy or gender bias or classism, removing that from your life is not charity either. That's justice. So we're in the middle of our timeline. As you can see, this is some of the work that we plan to do to take it to the Board of Supervisors. And one of the things we found just right off the bat was that the current Patient Bill of Rights wasn't available in Spanish on their website. Right? They had it in English, not available in Spanish. So there's these racism that can happen, and that's, we can go back and forth on whether that's an act of racism necessarily, but it's these types of obstacles are unnecessary, right? And there's racism in big ways that we can very clearly see, but there's also these everyday little chips away at our access that are really the inadequacies of the healthcare system. This is a vision that we created for organizing. I'm not going to read the whole vision, but this is the healthcare system that the clients and the patients who we're organizing with want to see, right? This is what they want to see for the world. And this is really a vision for healthcare that belongs to the community and that is free from racism, classism, and gender bias. Just have a couple more slides. So we just had a retreat, a 3-day retreat where we brought about 48 Latina patients to the Redwoods for a weekend to do a deep dive into organizing, to talk about racism in healthcare, and to look at the current Patient Bill of Rights and draft our own. These are the 11 buckets that our patient committee and growing base of powerful patients has developed. Access to care, respectful care, housing-related health needs,
Darcy, are you able to,
and with that, I just wanted to say thank you so much for having us here today. Thank you for acknowledging the issue of race and gender in healthcare and how that aligned with income and dollars really creates so much unnecessary human suffering. And just to recap, our solution to it is building powerful patient populations and collectively using that power to advocate, create leverage, and make demands of hospital systems that make our systems more equitable, more just, but through the power of patients. Thank you.
Thank you so much, Darcy. That was a wonderful presentation, and I hope you would be able to send us the link to the report when it's done so that we can share it with the people that were on this call. We had one, hopefully people will be able to spend just a couple more minutes because I have a very good question from one of the members of the participant audience. Is systemic racism, unconscious or not, in healthcare higher or lower than in other areas, such as housing? And is there something unique about healthcare that makes it different, if so? Could you talk to that, Dr. Rogers?
That's a good question. Structural racism is in every field. It's everywhere. And it's invisible too, because it's like, if you look at a house, you don't look at the structure of the house, you look at the rooms, you look at the kitchen, whatever it is that you want to see. So it is often invisible, but it's the core of how the system works. And I mean, when we look at healthcare, you know, we have the structure of the system is, you know, based on who can afford to pay for it and who has access to the care. And if you look at the way things are in this country, is who are the people who have the least amount of money, who are the people that live in areas where it is not accessible. And so that's part of the structural racism, that it's difficult to achieve, and it's not dependent on just one person to do or not do something. That's how it can persist, you know. So it's because it's so invisible, people don't even see it. And that's why they often think, oh, it's just me, I'm the one with this problem. But I mean, little things, if you look at how to get a mortgage for a house, the structural racism in there. You know, it's not just about the money that you make. You know, why can't Black people get mortgages? A lot of it is because if you're renting, what you pay in rent doesn't affect your credit score. You know, you can pay it on time and the amount may even be more than what the mortgage would be. But if you miss your cell phone payment once, that affects your credit score. That's the structure. It's not up to the person who can give the check to the mortgage company. It's the structure that makes it like that. And it's the same thing with healthcare. And that because of the social determinants of health, that's what is challenging you, even with the best insurance and money in your pocket. If you don't live near a grocery store, you won't be able to eat healthy. You know, if you can't get a COVID vaccine, if you look at when COVID came out, all of these structural things that made it more difficult for those who were at highest risk. You know, who can go to a drive-through testing if you don't have a car? You know, it's very complicated, but the structure is not built to help the people who need it the most.
Yeah.
Can I add something just about the second part of the question?
You sure can.
Yeah, because I would suspect that whether like for the first part, whether it's higher or lower in other systems, it just persists across. Like if I think of these systems more as a web than like separate systems, right? And so it persists in all of the systems and it interacts with people differently depending on the identities that they are bringing to the table, right? And so like their race, their income, their all of these, like the Kimberly Crenshaw intersectionality aspect of it, right, is really apparent. So I think of the systems more as these webs, right, that can either support and help you based on your skin color and race and gender, or can conspire against you. But in regards to the second question, One of the things that there are probably unique aspects of each of these systems, but one of the things that it continues to be the most jarring to me is when we interact with patients who have clear indicators that their medical provider is holding a racial bias against them, and potentially even a disdain, right? Potentially even like an unsavory feeling, and they are dependent on that person to save their life. They are dependent on that person to put them under, to do surgery on them. That I have seen patients who break out in tears and hide. They are so stressed because the interaction that they've had with this medical provider has been so bad. But because they're undocumented and until recently on restricted Medi-Cal, right, emergency Medi-Cal, because their insurance doesn't allow them to go just find another doctor, right, to just go and find another place. Well, this place has treated me poorly. This place has been disrespectful to me. This place has let me know that because of one of the identities I'm bringing to the table, they think a certain thing of me. I'm not able to just switch my care. So now I have to get life-saving cancer treatment or a surgery from a person who I know, at least my perception is, doesn't like me, doesn't like what community I'm from, is holding a bias about me, is shaming me because of my behavior, shaming me because of my individual choices. And then you are forced to get care from that person. That may also happen in other places, right? You may have a landlord and you're not able to move, or you may have, but it never stops being insidious. It never stops being so jarring to me that people are forced to do that. And so I think that may be a unique aspect to healthcare. The vulnerability and the power dynamic that a patient has who is in need of care.
Okay, thank you, Darcy. I also have a comment from one of our participants, Dr. Henry Abrams. Dr. Abrams, did you want to make add to the conversation?
I thank you. I would like to make a brief comment, and I want to commend listeners for the many aspects of the problem. And it involves individual healthcare clinicians. It involves the insurance system. It involves laws. It involves the social determinants of health. So there are all of these aspects, and the problem does seem like it's going to take generations to really repair the damage of racism. But I want to say to my league colleagues that there's one thing that we can do. It's not going to solve the whole problem, but it is going to eliminate enormous barriers to healthcare that's available to everybody, that's affordable, that's equitable, and that's high quality. And that is to work for passage of legislation to create a single payer healthcare system, either in the country as a whole or in the state of California. And there's legislation. I mean, this is a campaign that's been going on for a long time, for decades. But the League, which at one time was a member of a coalition in California to work for single payer legislation, has stopped doing that. And the League could rejoin the coalition in California and could work on a national basis. The League's position on healthcare is that it favors a single payer healthcare system. Those are wonderful words. They're wonderful sentiments. We need to get the League to actively advocate and lobby for a single payer healthcare system. And once we pass that legislation, then everybody will be treated the same, regardless of their race, regardless of their economic status. And then we can continue to work on attitudes, systemic racism and so on. But we need to remove a system which is stacked against making this problem solvable. Thank you.
What do our
Dr.
speakers
Abrams.
What do our speakers say to that?
Dr. Rogers, if you'd like
Well,
to.
Yeah. Hi, Dr. Abrams. Good to see you. I know him well, but I think one of the things that I think we have to be aware of that in this country, racism is so deeply embedded in the culture that look at what happened to Serena Williams.
Yeah.
She goes in the house. She could have bought the hospital. I mean, money was not the issue at all.
Yeah.
And there's a substance called, there's a theory called weathering. It's never, I don't think it's been definitely proven, but we know about it, that it's just the stress of being a minority, of being poor, living in this country that wears your body out and you get weathered. And that's the theory of why Black women in their 20s have worse childbirth outcomes than teenagers, Black teenagers, because they've been weathered, they've been beat down. So I think that even though single payer, which will relieve some of the financial stress and will open the door so that one is able to see a doctor, the people who don't want to see you will still be there. And they will still get into medical school, and they will still be, and physicians and dentists and nurses and everyone else is part of the healthcare system. So it clearly will help. Single payer clearly will make a difference, and I am a strong advocate for single payer, but we still will need more so that people can live healthy lives.
Yeah, I wanted to add that. Oh, sorry. That I also am a proponent of single payer, and it won't eradicate racism from the healthcare system. It won't ensure that people are treated equally. There, bias exists in all of our government systems. Racism exists in many of our government systems. As I had mentioned earlier in the presentation, healthcare is political because it's about the use of resources. Having said that, like if we acknowledge that up front, right, and we can go, eyes wide open into creating new systems that don't exist, which I'm also a big proponent of, with the understanding that in order to make sure that a different payer system doesn't just recreate the racism that exists in this payer system, we have to be actively creating policies that prevent it from happening, right? So if there's not active policymaking to prevent racism and bias from being entrenched in just a different system, and this is like part of that conversation is this continued tension between focusing on class and focusing on race, and those within the single payer movement who were like, it's class, it's not race, right? And those who are like, it's class and it's race. That has to be resolved within that movement as well, because as we heard Dr. Rogers say, like there are Black women who have much resource and are still, right, unnecessarily suffering and dying because of racism that exists. So I think yes to single payer, and we have to be like actively creating anti-racist policies within the single payer system, not as an afterthought, but like baked in it from the start. And there are some policymakers who are having those conversations, but I certainly don't hear those conversations happening enough in tandem with recognizing that it is 100% possible to recreate the racist structures that exist in our multiple payer system within a single payer healthcare system if we aren't intentional about if we don't have with intention, prevent that from happening.
Well, since this is a historically systemic situation, it's going to take a while and has to be a systemic solution. And I'm hoping that this program will be one of the ways we can help educate people to address it. And now, if are there any other questions from the audience? Okay, I would like to turn over the program now to Kathleen, who has a few comments to make about the Bay Area League.
Oh, thank you very much. This presentation is at the bottom of what we in the Bay Area League, we are the interleague, your interleague organization, doing your advocacy arm and looking at how decision-making at the regional level, how it impacts us and the issues. And equity is a critical part of it. And we're really, in fact, we're involved right now. Part of our study is the decision making and what our positions are, and looking at the equity and the systemic issues that are there, and how we can, in a sense, be part of the policy making and then affect the policy making. So we're just one piece of it. Look ahead. Want to invite you. We will have our biennial convention on June 1st. And we weren't going to do it in person, but in the feeling that we want to be able to get as many people involved as possible as we discuss these issues and show you what we're doing moving forward, we will probably have it as a Zoom kind of talking back and forth. And I just want to encourage you, yes, these presentations are available, as you could see in the chat. We mentioned we will also send out the link and other things to all the those who registered. And go to our website and you can find the other presentations. This is ongoing. It's just one piece, and it's enough to be able to move forward. And we wanted to make sure you heard from our different speakers. What can we do to support their efforts, as well as what efforts we can do to be part of the solution? So welcome. And April is, amongst other things, National Health Month. And there's a whole list of things it is. And it's part of what we want to do. Let's have a good day moving forward. Thank you to our speakers. Thank you, Marianne. Thank you, Reina, for what you are doing. Thank you, Henry Abrams, Dr. Abrams. I know about the committee, and I think as you called out to the leagues, yes, I think we need to step up and help keeping it moving forward. One solution, and we need many more. Thank you.
Thank you, Kathleen. And now I would like to thank again Dr. Rogers and Darcy Green for their excellent presentations. The comments in the chat are really appreciative of all people have learned during this, and Dr. Abrams, all people have learned during this session. And thank you, participants, for coming, for showing up, for showing your interest in the topics. We will be continuing the series with programs on education and the impact of healthcare on education. And I welcome you to continue to participate in these events from the Bay Area League. And thank you again.
Thank you so
Thank
much.
for having me.